welcome. And based on everyone's ability to maneuver to the open seats, we are quite a non-compliant group of patients, I can tell out of the gates. But we're really excited to be here with you today. And I think we have a bit of a unique conversation to have, especially as we talk about digital health and the scale and the actual impact that we can deliver through that. So before we get into who our panelists are, we just want to kind of level set a little bit about how we leverage musculoskeletal care in the US today. So musculoskeletal care as a budgetary line item is bigger than the Department of Defense. 50% of us will likely have some musculoskeletal condition over the next year. And on average, it takes anywhere between 24 and 52 days to see a specialist in the US. So these are all stats that are pretty staggering that we experience as we try to navigate our own healthcare systems and manage our own care. But think about folks who may not be as equipped as we are, who may not work in healthcare, who may not be able to call a physician as a friend and say, hey, can you get me in to see a specialist? So I hope through the course of today's conversation, we can really highlight some of the things that we've been working on at Sitka as we're trying to bridge the gap between working with self-insured employers and payers and actually bringing transparency and trust and really the promise of delivering healthcare digitally through our folks. So let me turn to our panelists and have them introduce themselves with Oscar. So Oscar, this is kind of an atypical environment for you to find yourself in. You're here in San Francisco at Rock Health, and tell us a little bit about why it's atypical and what you do and your experience with Sitka.
Yeah, no, this is definitely a first for me. I'm in the renovation business. I'm from Los Angeles. I'm 35 years old. Back in early 2015, I actually hurt my back. I bent over to pick up my son's diaper bag, and I collapsed from the pain. And that day started the worst 3 years of my life up until recently. I saw countless doctors. I was put on countless medications, opiates, muscle relaxers, you name it. The treatment that I got, I felt it was more of a blanket treatment. They just kind of come clock in and, there's no real, patient on doctor, I felt that I wasn't getting the treatment that I should have.
Yeah. Well, maybe if we can just briefly roll your video and
Sure.
how you met Dr. Gollogly here and give us
Absolutely.
an example of the experience that you had, and then we can learn more about that.
Yeah, absolutely.
If we can roll the video, please.
Good morning, Oscar. This is Dr. Gollogly. I'm an orthopedic spine surgeon in Monterey, California. And on behalf of your health plan, I'm going to go through your MRI scan here and explain what's going on so that we can help you make a really good decision about what to do next. So to take you on a guided tour of your MRI scan, the first thing we're going to do is label the vertebral bodies or bones in your spine. So starting on this image here, which is called the sagittal image, this is the L5 vertebral body, which is the lowest vertebral body or bone in the lumbar spine. And above that, we have L4, L3, L2, L1, and then T12, which is the beginning of the thoracic spine because the ribs are attached. In between each of the vertebral bodies is an intervertebral disc. So this, for example, is the L4-5 disc. So named because it separates the L4 from the L5 vertebral body, acting as a shock absorber into the joint. Behind the vertebral bodies and the intervertebral discs is the spinal canal. All
right, we can kill the video just since we're not all in anatomy class still. But Oscar, how did you receive that video, and then what did you do next? And on average, these videos are 3 minutes long, but what did that do for you and your wife and your family?
When I found Dr. Gollogly through my health provider, I was really impressed by how personal his videos were. When he sent me the video, it was directed at me. When he said my name, it stunned me. I stopped and I called my wife. Look, he's talking to me.
Huh?
And
this weird phenomenon, right?
Yeah, really, this was something that I wasn't used to. And I sent the video to several family members, and they were all stunned. They were all they were all very impressed at how personal this was.
Yeah.
And after very little back and forth, I think the next day I ended up getting an appointment and drove up from Los Angeles, and everything came together, fairly quickly. Within a couple weeks, I was in the surgery room.
Great.
Yeah.
And so that's your experience as a patient, and we'll come back to that certainly through the course of our conversation today. But Nancye, you work for a beloved brand of mine, the parent company, VF Outdoor, of North Face, of Smartwool, Reef, JanSport, Lee, yada, 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 the list goes on. Vans, yes, of course, not that we're advertising, but yes. And so as an employer, and you've been in HR for a long time, and thinking about how this experience can actually be delivered through VF Outdoor and through your employees, talk a little bit about you guys as a company, how you think about your 70,000 associates and athletes worldwide, and how the patient engagement is with a product like Sitka.
Well, the most important feature is that the engagement can happen wherever my employees are around the world, and not just in a store or an office, but we have athletes, and our employees are athletes. So they may be climbing Bhutan, they may be up in Mount Rainier, and for some reason they developed an injury or an old back injury or an old back issue pops up. They can get this immediate interaction. They can go to another medical facility, get an MRI done, and it can be made available to Dr. Gollogly, and he can have that interaction with our team members. I did some research with our benefits people, and we've got a group of people, small group of people, that take about 3 days every 3 months or so away from work to rest their backs. Whether they're working in the office or they're working in the stock rooms, or they're our athletes or out accompanying our athletes, our sports marketing team. So it really increases the engagement. And again, as a self-insured employer, we have that flexibility of making a benefit like this available to our team members.
Great. And so, Dr. Gollogly, I've had the benefit of knowing you for almost 5 years now. I've seen you tinker and help evolve this that really stemmed from your desire to actually just deliver better patient care. And we've now obviously transitioned it and founded a company around it, and found a little bit of a market fit with the self-insured employers. But talk a little bit about what drove you to kind of be relentless about experimenting and having better connectivity and trust with your patients.
Yeah, so the process that Oscar went through was something that I just clutched together in my own clinic, really trying to solve for a problem of physician burnout and difficulty in achieving literacy in my patients and getting them to make educated decisions that I felt like I would make myself, or I would educate a family member to make. And we have this problem in medicine where there's this very, very tight window of opportunity to deliver a lot of very complex and technical information to a person in a very, very short period of time. And I think for a lot of patients it can be really overwhelming. And that asymmetry of knowledge that's present in a clinical exam room, which is oftentimes a very threatening space for a patient, and it's a really difficult space for them to listen and to be receptive, was something that was kind of really stymieing me in medical practice. So I developed the ability for patients to upload their medical imaging data before they ever came to see me. And I would review their scans for them just the way that I did with Oscar. And it would be delivered initially via a rather unsecure format, YouTube unlisted videos. But what was really amazing about it is that without having the constraints of HIPAA, I knew what the patient engagement was because I could track it through YouTube analytics. And these patients were watching these videos 15 times before they'd ever come in and see me. And it completely transformed my clinical practice. All of a sudden, I had like this magical degree of literacy on behalf of my patients. It was really easy to get them to buy into non-operative care. It was easy to get them to understand the risks that opiates were playing in their care cycles. And then for those patients who needed operations, it was actually really easy to get them educated to a much higher degree that I felt like met the standard of care for informed consent than the analog equivalent. So obviously, I was running this program in my practice. I knew Kelsey socially. We started collecting a fair amount of data on patients. I put about 700 patients through the MRI, the early version of the MRI review process in 2017. And got pretty good PRO data on that cohort of patients. So when we asked patients on a scale of 1 to 10, how much the experience of having their medical data reviewed and then delivered asynchronously like this prior to their clinic visit or after their clinic visit affected their experience of the healthcare system, with 1 being it didn't change their experience at all and 10 being it was the best experience they ever had at healthcare. 75% of the patients who went through the process said it was a 9 or 10 out of 10. which was kind of, after 13 or 14 years of higher education, of college, medical school, residency, and fellowship, it was kind of disappointing to be that the most transformational thing that I ever did was publish something on YouTube. I thought that it was going to be some brilliant surgeon, and it turns out that in a world that we're in today where a lot of medicine is a mature science and there's a tremendous amount of data out there, it's really our ability to communicate about it that is probably the most important key to achieving really good outcomes. So it transformed my clinical practice. It sort of transformed me personally. It rejuvenated my my interest and my enthusiasm and my passion about spine surgery and helping people make really good decisions about their back. And then obviously, given the data that we had and the relationships that we had with the developing relationships we had with risk-bearing entities, it became apparent that we could do this on a larger scale and act as a digital triage agent on behalf of risk-bearing entities to make sure that people established the right relationship with the right doctor right off the bat, as opposed to entering into a cycle of potentially unnecessary and expensive treatment options. So that's kind of a summary of how we ended up here.
Yeah. So Oscar, you talked about over lunch today about how you spent kind of 3 years, right? In the system looking for answers. And one of the questions that we often get about Sitka and when we partner and actually produce guided MRIs with self-insured employers is this concept of a second opinion. So Sohrab, I was wondering if you could talk a little bit about kind of the evolution of how we think about second opinions, and then Oscar, I'll come back to you about kind of your experience receiving it.
Yeah, so there's probably people in this audience that are members of this, part of the second opinion industry, with some very well-known players. And the challenge for me is really a second opinion is only necessary when the patient doesn't have faith that they're getting that the first opinion is transparent and it's trustworthy and that they understand it. And I actually think that a lot of the clinical desire for second opinions comes from a lack of understanding of the first opinion. So what we've really tried to establish with Sitka is the idea that if we can get someone appropriately educated about the natural history of their disease, their treatment options, if we can very importantly inoculate them against overtreatment so that they're aware that, for instance, in Oscar's case, he had no significant spinal instability, he didn't need a fusion operation, and he needed to get off his narcotics. That may be one of the most important battles that we fight in the care of someone like Oscar. And being able to do this with the technology platform that we developed with Sitka really frees us from the tyranny of synchronicity. I can move the ball forward without having to see Oscar in my clinic, which is a really difficult environment sometimes to achieve those goals.
Oscar, you talked about that after your 3 years of kind of cycling around and ending up on some unfortunate pain pills for a period of time and becoming somewhat addicted to them and relying upon them, what your experience was for the first time when you received that guided MRI, that it was the first time that you actually saw your own body. What was that like?
Well, nobody's ever explained my MRI to me. I've had doctors review it and just kind of take notes down and tell me what I need to do. I actually got many diagnoses. I had, I think Dr. G was like my eighth opinion. So it was something else to have him, sit there and explain to me, what was wrong with my back, in different steps. Something I had never experienced before. Yeah.
Nancye, in conversation that we had as well, you talked about just the timeliness that you like for your employees to be able to have access to this knowledge of their own body and kind of a routing and a care plan that's at least delivered within hours of receiving their MRI. Can you talk a little bit about what that does actually functionally for your
Well, it's critical in terms of the sponsored athletes that we have, because they can be out on an excursion. We sent a group down to Antarctica, and if any of them had been injured, the whole expedition would have been put at risk. And so this way they would get quicker diagnosis. But the other aspect, as Sohrab was saying, it's also the alternative. It's not necessarily that because you have this backache, this neck ache, that you're a surgical candidate. And I think that's sometimes what is missing from it. People right away go into the mindset that I'm going to have surgery, and then they don't want to deal with it and they don't want to get treated. And so for us, that's going to be more time away from work. They're going to be frustrated, they're going to remain in pain because they don't want to deal with it, and then their performance is going to fall off. And we can't afford to have that performance fall off in our key players in the office. And those are the folks that are out there all the time putting themselves at risk for injury.
Yeah, yeah. So Oscar, because our analytics tells us how many times people watch their videos and where they're located and things like that, we know that you shared your video and that your family members got to watch it all over. Sohrab, we recently had an experience where a patient watched their video. The count this morning was 107, and this video was produced on October 8th. So tell us a little bit about this kind of unique case, but not totally an outlier for how many times people watch these 3-minute videos.
Yeah, so kind of a funny story. So I was on call over the weekend, and I took care of a patient last week who sustained an ankle fracture, and her daughter is a physiotherapist at the Stanmore Royal Orthopedic Hospital in England. And I think that she was a little surprised with the ability to connect with me as a consultant surgeon. I think those people are kind of behind wraps in the NHS as opposed to the availability that I have. I give all my patients my cell number and my email address. So I recorded her preoperative video and said, look, here's your ankle fracture. Here's the plan for how we're going to treat it afterwards. I did the same thing using the same platform afterwards. These are your post-operative X-rays. This is what I was able to achieve. Here's the post-operative plan. She forwarded it to her daughter, and I think it's been seen by the entire NHS in the next couple of days, which I'm hoping is like, well, that's the way they do it in Silicon Valley. Maybe it'll come to London at some point. And you know, the thing that I like about this platform is it kind of gives me the opportunity to treat people free from the natural prejudices that are just these decision-making traps that catch all of us in clinical medicine. You know, one of the things that was really fun about Oscar, and one of the reasons why we invited him up here, is I obviously never got to see him before I reviewed his MRI scan. And so when he walked into the office, the first thing I said to him, I said, Oscar, you know, you look like kind of a tough guy. Like, if this doesn't work out, are your friends going to come over here and kick my ass? And he was like, no, you're actually kind of like the first person who ever really took an interest in me and my MRI scan. So that's the reason why we sort of bonded as a doctor and patient. And that's really what this technology has been able to do for me, is it's actually been able, it's enabled me to develop a much better bond with the patients that I take care of than I ever had in kind of the analog experience, because, you know, Oscar and his family gets the opportunity to watch this video 15, 20 times before they come and see me. They're comfortable with the vocabulary. They don't feel like I'm talking down to them. They can stop and look things up. And so that information asymmetry problem is really solved, and then I get to meet Oscar on terms that I think are much more equal than if he just simply walked off the street and I'm there kind of with my back to him, typing into Epic, telling him what's wrong with his back.
Great. So I think you mentioned something that is really important in the broader context that is often a discussion right now, which is kind of the opioid crisis that we find ourselves in. And obviously there's a lot of people tackling this, and you know, early on, we even contemplated making Sitka focused on opioid reductions because of some of the early results that we had with our patient population. So Sohrab, you have a perspective and experience with this from a physician standpoint. Oscar, you have one, and Nancye, you have one from an employer. So I'd love to kind of hear the three of your perspectives on this, starting with Sohrab.
Oscar, why don't you go first and tell us about what happened to you with opiates?
Well, like I said, doctors would just write me prescriptions, send me on my way, you know, and they had a line out, you know, out the door in the waiting rooms. I ended up becoming very addicted to the pills. I'm still struggling now, you know. Mm-hmm. I've come a long way, but I still struggle on a daily basis. But yeah, opiates are definitely.
And that experience of getting written another prescription, it was pretty transactional, I'm assuming. And did you feel like that the physicians actually knew you, or what was that experience like?
And did anyone ever talk to you about the alternatives?
Alternatives, no. I don't remember anybody ever talking about it. Like I said, I just walk in the office, they jot down a couple notes here and there. They needed me to go to the office because they needed it, you know, see my face or whatever. And write me a new prescription, and I'm on my way. See you next month. That's pretty much it was for about 2 years, a little over 2 years.
Yeah. Mm-hmm. Nancye, how about you? How do you guys think about this from a self-insured employer standpoint?
It makes so much more sense to have it, because then it's not in the workplace and we don't have to, I mean, we work in a very relaxed environment, and the last thing that we would want to have to be exposed to is conducting drug screening for our patient, for our employees. The other pieces too is where Oscar is a patient, I'm a caretaker of a patient. And for him, my husband was the same way. Here's painkillers. Just take them and you'll feel better in the morning. And after our interaction and surgical intervention, my husband took 2 days of painkillers and then was on Tylenol and ibuprofen for 2 weeks, and then just back to all regular activity, except swinging a golf club, because that's just beyond him right now.
Absolutely.
Yeah, so I entered medical school in '94, graduated in '98, which was really the sort of beginning of the run-up to the opioid crisis, whereas physicians, we were taught during that period of time that we should give patients pain medication while they were in pain, and once their medical episode finished, they no longer would perceive the need for further pain medication, and we know that to be an amazing lie perpetrated on us by Purdue Pharma. One of the things that's so fascinating about it is that there are actually alternatives out there that are much less harmful. Specifically for acute and post-operative pain, the combination of Tylenol and ibuprofen has been proven in a very well done paper published in the Journal of the American Medical Association in November of 2017 to be just as effective as intravenous morphine for acute pain associated with surgery and with acute fractures. But getting that message across to patients is really difficult, and it requires repetition and it requires reinforcement. And you have to battle against the influences that are out there in the media all day, every day about the opioid crisis and the perception that the only way to control pain is these incredibly dangerous substances. And on top of that, as a clinician, if anybody here practices spine surgery or has ever spent a day in a spine clinic, one of the biggest challenges in the United States with the opioid crisis is that back pain is the single most societally acceptable way to say, I just kind of don't really feel like coping anymore, I don't want to go to work, and I'd rather sit on the couch and take pain medications. And one of the challenges as spine surgeons is that those patients typically exhaust the abilities of their primary care providers, physical therapists, massage therapists, and acupuncturists relatively quickly. So they show up in my office, usually after they've been on narcotics for 6 to 8 weeks, which is long enough to give them a significant addiction problem, with an empty bottle of pain pills and an MRI scan that is read by the radiologist as abnormal, but as spine surgeons we would look at as normal as a function of age. So trying to get that person to understand the trap that they're in within about 15 minutes is really difficult. And so the actual first use case that I had for Sitka was reviewing people's scans and saying, look, there's nothing on this MRI scan, there's no compelling reason why you need to have an operation. And the number one thing that you need to do here is get off the pain pills if you're on them now. So I'd like to make sure that you watch the video that I have on my YouTube channel called Why Pain Pills Are Not Your Best Friend. And that process changed that conversation entirely, because at least I had patients coming into the clinic instead of saying, the radiologist says that my MRI scan says I have 3 blown discs and I need to refill my pain pills because that's the only thing that was working. At least I had patients coming in and saying, I now understand that my MRI scan has got some abnormalities, but that's normal as a function of age, and I also understand there are alternatives. Now I'm paraphrasing, but that's essentially what I was able to get out of them for that. So what I've been able to do with this technology platform is reinforce the message that there are a lot of conditions in the spine that may seem abnormal, but patients should have faith in the natural history of these conditions, and that physical therapy, non-operative care, acupuncture, massage therapy, yoga, all of those things work, and narcotics are not a reasonable solution for the management of these long-term conditions. And then I'm also able to reinforce my messages about the very judicious use of narcotics post-operatively. So I used to write scripts after every single operation that I did for 60 10 milligram Norco tablets, and I would expect to refill it once or twice. So I used to give the average patient that I operated on, I do about 300 to 350 operations a year, somewhere between 120 and 180 10 milligram Norco tablets, and if there's physicians in the room, I know that's the standard practice for anybody that's doing surgery. And as a result of the asynchronous communication platform that I have now and the ability to reinforce these messages, I now put everybody on Tylenol and ibuprofen, and I give them 10 5 milligram oxycodone tablets after every single operation I do, and that's it. So I've reduced my narcotic prescriptions with this system by 90%. I've gone from basically an average of 120 to 180 tablets to now less than 10 on everybody. And what's amazed me about it is I have really good data on those patients to show that their perception of the pain control after their operations is that it's better than their previous operations. And since the average American now has 8 or 9 operations in the course of their lifetime, I've got pretty good data to suggest that it's actually better than these heavy narcotic prescriptions.
So as we think about scaling, and particularly having to work with physicians, dare we say, and trying to change workflow, one of the questions that's popped in that coincides with the conversation we want to have today is, how does this fit into your workflow today? How does this fit in with workflows like self-insured employers and payers, which is how Oscar found us? Talk a little bit about how folks implement this inside their own practice.
Yeah, so obviously we have had a lot of interest from physicians who would like to use this type of service. As a company, as Sitka, what we're really trying to do is act as a digital triage agent on behalf of risk-bearing entities such as self-insured organizations or large medical systems to help them triage their patients to the best physician to take care of their particular problem at that time. And the way that we imagine doing that is that as a network, we'll be alerted when someone's had an MRI scan, so that before that patient is allowed to get into a catastrophic, what we describe as catastrophization of healthcare, because they'll get the MRI report oftentimes before they have the opportunity to see a specialist who will put that MRI report in context. Oftentimes they'll get a copy of the report, they'll start typing those terms into Google, and they're left with the impression that they have some amazing disability as a result of this MRI scan that's essentially normal for age. When I review someone's scan, and I keep up with all my consult requests this way, when I have the opportunity to review someone's scans within 24 hours of the time that it hits our server, it gives me the opportunity to really kind of talk them down off that ledge and get them to understand that a lot of these findings are normal for age. So we imagine hiring a workforce of people to do that on behalf of risk-bearing entities at scale.
And Nancye, when we work with folks like yourselves and we implement this and are actually put at the UM and pre-authorization process, and then the employees are routed to us, can you talk a little bit about just how the response has been, your personal experience with how folks have received it and the implementation of it?
It's the speed.
Yeah.
It's the speed of it, and also that they're making contact with a real surgeon who's behaving like a real person and is treating them like a real person.
Yeah.
And so there's an investment that's made.
Yeah.
So they'll make a much better informed decision, and you've taken that level of anxiety away from them, so that when they do show up for clinic, they're not in a panic mode and they're actually paying attention and listening.
Yeah.
Yeah, good point. I mean, we had a patient early on that was pretty instructive that told me, she's like, I watched your video at home in bed after I put the kids to sleep with my husband with the covers pulled over our head on my iPhone. And she was like, that was the first time I understood what was wrong with my back. And that's a completely different environment than being in my clinic when, I'm an hour and a half late and the kids need to be picked up and, all of the usual sort of things that make our clinic experiences, for those of you who see physicians that aren't concierge physicians, the usual kind of hectic scrum that medical practice sometimes can be.
Yeah, one of the things that I found really interesting from a clinical perspective, so I've been watching you use this and expand to other physicians and bring on other physicians, is the opportunity for you to actually say, no, I'm not the right physician for you, patient, to see. Let me route you appropriately. And there was a question a little bit about kind of what are some of the decision-making traps that Sitka and asynchronous delivery and review of a complex data set, being an MRI, actually help you avoid as a clinician?
Yeah, it gives me a great way to say no, no very politely and gently. So if someone, if I get an emergency request for a consultation at 4 o'clock in the afternoon on a Friday and I look at their scan and I'm like, hey, look, this scan's normal. This gives me the opportunity to say, hey, I've looked at your scan, there's no huge disc herniation here, no spondylolisthesis, no disc infection, nothing that's gonna warrant surgical intervention. What I'd like to do is have my assistant set you up with our physical therapist, and then you can come and see me in 3 or 4 weeks when next available, and at that point we can talk about what's working and what's not working. And that's a completely different clinical course than allowing that patient to sit at home and stew in an atmosphere of fear and uncertainty and doubt, oftentimes when they're using narcotics to help manage that anxiety, and they're not using the appropriate medications to help with their physical pain, and at the same time they're avoiding the things that we know work, such as physical rehabilitation in that situation. So it gives me the opportunity to say no very gently for my own specialty, like you don't need to see a surgeon yet, you need to see a physical therapist. It gives me the opportunity to route to other people in my practice very, very efficiently. So oftentimes in my community now, because I have this platform, I'm oftentimes called by the oncologists, by the general surgeons, by everybody saying, hey, will you take a look at this MRI scan and tell the patient what to do next? And so then at least I can get the patient properly educated and on the way to see the right specialist to make sure that process is handled. And because these videos, depending upon the way that the platform is being used, can be shared with some members of the care team, it also gives me the ability to deliver it to the medical assistants and the people that route those patients, so that there's not this constant process of referral and re-referral, because as we know, one of the biggest challenges in the US is that oftentimes the person that's making that referral may not have the appropriate insight into who the best specialist is to see that patient. So there's an incredible number in the millions of unnecessary referrals to specialists that occur each year that then result in re-referrals because that wasn't the appropriate treating specialist in the end. So our hope is in the long run that we'll be able to short circuit that by becoming essentially a smart digital triage network.
Yeah, and one of the other questions that folks have been asking about is that, well, we start with the kind of orthopod and musculoskeletal in general, and that's the experience that you had with us, Oscar, with your back and your MRI of your lumbar spine. But Nancye, how could you see this expanding beyond ortho for your population at VF? Is it oncology, or what are some of the other things that you really see that are some of the top items within your population that you're looking to manage, not only from kind of an absenteeism perspective, but also from a sheer cost perspective and how you guys are spending your money?
One of the first things I thought of, given our population, is sonograms. We have a young population, and we're in our third wave of a baby boom right now. And all I hear are, I hear these women coming back into the office, or the guys coming back in after they've gone with their wives, and they're saying, I have no idea what I was looking at. And they're meeting, and the doctor's not there when they're doing it, they're having the technician do it. And so nobody's really communicating with them. And if there is some issue there, they don't know either. And of course, from an oncology standpoint, again, it's all about allaying fear and engaging earlier. So we're engaging with our employees, we're extending our care to them, and we're also then extending the care of a physician and building that partnership with them sooner than later.
Great, and so that's from an employer perspective. So from a clinical perspective, where do you see that Sitka can go in expanding verticals, given that I think one of the things that we talk about is that at the end of the day, we actually are just kind of translating and interpreting a complex data set.
Yeah, obviously we're starting with musculoskeletal medicine because there's nothing like home cooking. I mean, that's what I know best. And there's a figure out there, and I've seen it said it's 70%. 70% of medical decisions in the United States now are made on the basis of the review of data. In spite of what our professors of internal medicine taught us back in medical school, the physical examination and the in-person examination is oftentimes becoming secondary to the laboratory data, the medical imaging data, the genetics that we heard about earlier, and that's just a very challenging environment to be able to communicate all of that information to the patient. So we anticipate that we'll expand into the verticals that rely a lot upon complex medical data, cardiology, gastroenterology, oncology, anything in which there's a bond that is, where the doctor-patient relationship is really based upon the physician being the person that contextualizes and interprets complex medical data on behalf of the patient. And I think what's really crucial in this process, and the thing that's been such a delight to me, is that especially when it comes to imaging, people want to see inside their own body. There's never been a better time to be a doctor, there's never been a worse time to be a doctor. It's never been possible to do more, see more, smaller incisions. The MRI scan is the most amazing tool to be able to look into the human body. There's never been a worse time to be a physician either. There's never been more forms to fill out and bureaucracy to navigate. And it's really great to be at this stage of my career and be able to kind of introduce patients to the artistry of modern diagnosis and the imagery. The imagery is beautiful, and being able to share that type of imagery with patients so that they can see it themselves is something that's really compelling to me as a practitioner. And obviously, Oscar, it was really compelling to you as well to be able to see for the first time, like, this is what a herniated disc looks like. I mean, this is my problem that's been plaguing me for the last 3 years.
Absolutely.
Yeah, so we take this example of Oscar, and there's a question that's coming in around kind of what is the broader financial model and how are we going to market and partnering with self-insured employers. And as we've kind of seen an era of the distribution and scale of technologies amongst large payers and local communities into physician offices, and kind of a trend away from the per member per month model with self-insured employers and employers at large. So if you want to talk a little bit about kind of some of the conversations and the structures that we have to date.
Yeah, in general, in exploring our market fit as a venture-backed startup company, what we're finding is that there's not a tremendous amount of enthusiasm for per member per month contracts. And instead, what we anticipate doing is charging a per episode fee, so that we'll charge a fee for reviewing someone's data, and then depending upon the number of touches required in order to get them into the hands of a curated network of physicians that we know will do a good job of taking care of them, There'll be a fee associated with that. And ultimately, as we develop data about the ability to save significant spend in these verticals, we would anticipate entering into shared savings or shared savings contracts with those entities. Ultimately, probably taking significant risk of saying that we can reduce your spend if we can have access to data in a timely fashion and route your patients accordingly. And the greatest thing about it is that the one thing about this platform that we don't struggle with is that when I hit somebody with a video, we don't have a problem with engagement. When it shows up in their inbox, they watch it 100% of the time.
Yeah, it's been a pretty fun thing as I've been in multiple different careers in healthcare and at United Health Group and Navi Health, and patient adherence has always been such a topic and something that's really difficult to crack. And it's certainly been a delightful experience to see the level of excitement that people actually have and almost like the love notes that come back to us as a result of this experience.
Yeah, and it echoes my clinical practice. I mean, I've been in practice for, I'm in my 15th year of practice, and, it wasn't until I started doing this that I felt like I was really kind of making headway. And it's completely transformed my clinical practice in a way that at least personally feels very much like improved compliance and understanding and education and shared decision making, much more so than some of the alternatives or some of the programs that I've seen offered as a format for shared decision making. This is the first time that's really enabled me to achieve that level of literacy and engagement.
Yeah, so when we think about scaling on the supply side as well and using physicians to help us deploy this, and I think one of the interesting kind of metrics that we oftentimes compare this to is just the amount of radiologists that read, thousands of reads a day. So can you talk a little bit about kind of the scalability and the physician network that we have?
Yeah, so a full-time radiologist in the Mayo Clinic reads about 6,000 three-dimensional scans a year. So those are MRI scans, CT scans, something with a stack of 100 plus images in them. The data contained in those images can be used to affect billions of dollars in healthcare spend if you take those 6,000 scans and multiply them by $100,000 per episode of care for musculoskeletal illness. It's a tremendous amount of money. And so the ability to simply take this data and to translate it into something that's transparent, that can be shared with patients, that the patient can review over and over again asynchronously, and can educate them to make really intelligent decisions, allows us to achieve scale that is far greater than the scale that I'm able to achieve in face-to-face interviews and consultation with all the leakage that occurs. The leakage that comes from lack of comprehension, the pace, the fact that it's not a particularly great receptive place for people to hear all this information. And based simply upon the fact that, the average time that one of my MRI interpretation videos watched is between 9 and 15 times, I know they can't get it the first time. So if I go through an MRI scan the first time and tell somebody, and that's my analog experience, and then I deliver it to them digitally and they watch it between 9 and 15 times, I know that a very small percentage of those patients are getting everything that they need to out of that face-to-face interview. So there's a built-in amazing scale factor, 9 to 15x. Every time I do a 3-minute video and it's watched 15 times by the patient, I get that much more comprehension. And when I multiply that by the ability to read 6,000 scans a year and kind of do 6,000 discrete digital triage events per year, it's not going to take a particularly large staff of physicians to help us help patients make some really good educated decisions throughout the ecosystem.
Yeah, and so Nancye, you obviously said on the employer side here, are there other cool digital technologies that you see that you guys are looking to adopt to manage your workforce, or what's going on in the land of workforce management from a healthcare perspective?
Nothing from a healthcare standpoint. This is all radical and brand new. Because again, it's always been very isolated and very traditional. You get hurt, you take time off, you go see a doctor, you recover, you take time off again for PT and whatever else. And so there hasn't been anything like this for us. And there hasn't been anybody, within our corporate structure, our headquarters structure, that's even pursued anything other than this.
And so Sohrab, you see a lot of other digital things and you get hit with, as a physician with, this solution and that solution and physical therapy online. And so where does this kind of fall on the spectrum of digital solutions that are promising at this early of the stage?
It's in there. Obviously we see a lot of shared decision-making programs, Sherpas, care navigators, second opinion services, and we know that these programs work. But we know in general, even the most mature ones with the most engaged employers are achieving very low single-digit engagement rates on behalf of their patients. So for a lot of these established second opinion services, even if the employer kind of mandates it, 6 to 9% of the patients or something like that are actually using the service. So what we're hoping with this process is that we can deliver something that can guide someone through a very complex, intimidating system like the medical healthcare system and make it as seamless and effortlessly as ordering the Lyft that everyone's going to order when they leave here this afternoon. Delivered to their phone on their own terms in a way that's asynchronous, that they can review, share with their family members, watch multiple times, take to somebody else, get a second opinion. It's that level of transparency that I really like, that I feel like really helps patients make good decisions in a complex space.
Great, and one of the things that we've been spending a lot of time with and has been surrounding our broader kind of conversations in digital health is the ability to scale, and obviously that is highly dependent on the reimbursement models that present within the federal government. And so as we heard earlier from Ann talking about Dr. Gottlieb and his work at the FDA, I think there is a lot of traction that we've been spending time on the policy front and on the telehealth front, and CMS has been pretty active these days on continuing to release positive directional efforts on actually being able to pay for asynchronous delivery of telehealth and other adoptions of technology like this.
Yep.
So with that, thank you guys so much for entertaining our conversation this afternoon, and we'll look forward to chatting with you soon.